E ngā mana e ngā reo, ngā mihi nui ki a koutou, e hui tahi nei ki te whakarewatia tēnei kaupapa whakahirehira nō reira. Nō te upoko o te ika, te rarawa me te aupauri o kuiwi, engari e noho ana ki te upoko o te ika. Te hiku o te ika come from, I'm now living into upoko o te ika. Nō reira, tēnā koutou, tēnā koutou, tēnā koutou katoa. My name's Teresa. I'm an ex-Deputy Director General, so I'm not quite at the level of an Ashley Bloomfield, and I do want to acknowledge that I think that Ashley has done a remarkable job for us in New Zealand in managing COVID and giving good advice to the government. I'm a member of Te Whakakaupapa, Te Rōpū Whakakaupapa Uruta, and the reason why this group stood up just as we went into level 2 was because we had a concern that government was not designing a response and giving good messaging to Māori communities. So Māori, the needs of Māori was absent in the messaging that government was giving out for COVID. So that's why we stood up, and I think that's one of the reasons why I was invited here to talk about reimagining health. And from my perspective, I'm talking about reimagining well-being and health for Māori people. So we know that, Professor Irupomari first started to report on the differences in health status in the 80s using 70s data. So we've known about these differences, considerable differences in health status for Māori for quite some time. We've actually known as a health system that there are differences between population groups. So in 1840, we signed the Treaty of Waitangi. In 1840, the Lancet published a graph which showed the difference of life expectancy for occupational groups. So those who are more in a better, higher paid occupation, the gentry, the landed gentry, lived longer than the farm worker. So we have known about these things for decades, actually probably a couple of centuries, and yet we still struggle to do anything about it. And so when I think about reimagining what the health system looks like or what health might look like, I'm really concerned about the populations. What does the health of a population look like? And how do we reimagine what we've got to do? So fundamental to making considerable change is considering how the social determinants, access to good housing, access to a living wage, access to employment, access to education is unevenly distributed across the populations. And the thing is that these are not random. It's the way in which we design our structures, it's the way in which we design our policy, and it's the way in which we use the levers and mechanisms that we've got available to us as policymakers, as funders and planners, and as clinicians. And so we can see that the system largely delivers to the population that the designers see. So they're predominantly non-Māori, non-Pacific, non-Asian people who design a health system for a population that within a very short number of years will look considerably different from what it's looking like now. And we still aren't able to put our mind's eye to that. So reimagining what a health system looks like is a health system that is much more sophisticated than it currently is, that is able to provide universal services for the whole of the population, but is actually able to think about what are the additional supports and services that different parts of the population need in order to, for them to realise good health. But I do really want to stress that when we talk about health, we tend to talk about health services. And health services actually aren't really about good health. They're really about somebody who's got ill health, and you now have to come to a system to either help you get better, or look after you because actually you are not going to get better, or else look after you as you depart this world. So when we're talking about good health, we really should be saying it's about all of the systems that are put in place that government says we are going to use your taxpayer money to fund, and to make sure that that is equally distributed across populations. Now, I want to talk specifically about Māori health because my job in the ministry was the DDG of Māori health, and for a short time, policy and strategy. But why I've spoken about the unequal distribution of the social determinants. But why are Māori so poorly represented in all the social indicators? And as I said, I don't think it's random. It's not an oopsie moment. It's been well organised. And part of that is you can see the impact of colonisation. So you get a coloniser coming in, and you lose not lose, as in I've lost my handbag, but you no longer have control of your own destiny. You no longer have control of the resources. So land is gone, land is lost. And that was certainly not a random event, and it's those sorts of concepts and those thoughts, things that inform people thinking that was the right thing to do when settling in Aotearoa, still continue today. So you still have this notion that somehow a treaty of Waitangi relationship is something that we should be grateful that it's been bestowed on us as Indigenous people of New Zealand. And I think that in order for us to make real change is that those partnerships, that relationship between the Crown and Māori needs to be a real one. And when I look at the health system, so 20 years ago, the New Zealand Public Health and Disability Act had a treaty clause in it. So the tribunal, the Waitangi Tribunal, recently in its Stage 1 report, condemned, well, not so much condemned, but made the point that the clause is less exploratory and much more reductionist. So it's a passive statement. And as you can see, when you track the changes that have occurred over the 20 years that clause has been in the New Zealand Public Health and Disability Act, unfortunately you can see that it has had very little impact on the health of Māori people or on the ability of Māori to interact and play a real governance role in district health boards. So these are opportunities that I think we need to think about, is better focus on equalising the distribution of the social determinants, good public health, thinking about the way in which the treaty statement in the legislation is, and certainly the tribunal and even the health and disability services review, colloquially called the Simpson Report, suggested that those amendments needed to be made in the legislation, and also that the legislation needed to be amended to make the requirement of DHBs to address inequities for different population groups much more concrete, and to ensure greater accountability and monitoring. And I can see through my mind's eye that I should be closing up. So just to quickly close up, is that both of those reports, I think it's useful in reimagining what Māori health or what the health system looks like, to have a look at both of those reports, because they're well reasoned and the recommendations are well founded, and I think they would be useful for this forum or any other forum to look and see how they can inform a new health system going forward. So, kia ora.
Kia ora.